Our moderator, I'd like to introduce to you. You've probably seen him behind the Immunolaboratories booth, and you probably think that maybe he's an employee. He is not, but he is like family. I'd like to introduce you to our moderator for the Diagnostic Interpretation panel discussion, Dr. Richard Powell. Dr. Powell is a practicing naturopathic physician and acupuncturist with dual degrees in naturopathy and oriental medicine. He also received and completed his PhD in nutrition. He currently has a full-time practice in the state of Idaho. For the past 2 years, he has spoken in front of hundreds of physicians from around the world in numerous seminars regarding food and environmental allergies to nutrition, pain management, and practice development. Dr. Powell has recently completed his book, The Physician's Field Guide to Optimal Health, that will be released as an e-book in January of 2009. Please join me in welcoming Dr. Powell. And also on the panel will be Dr. Mead, Dr. Lohman, Dr. Warden, and Dr. Woolger from today. We have a microphone up, and I know Dr. Powell has some questions that he'd like to ask the panelists. And then we're going to open it up for you doctors, and you can just come forward to the microphone, and that way we won't have to pass the microphone around.
Thank you. Well, we're wrapping it up. It's almost the end of the day. I'm sure everybody's extremely exhausted. It's been an action-packed 2 days of information that's been shared. I certainly want to thank Immunolaboratories for putting this event on for all of us. This is the second annual, and it has been absolutely terrific. So thank you. Panel discussion that we're going to be having today is going to be on diagnostic interpretation. And I would like to, I'm going to start with Dr. Lohman. Dr. Lohman, can you explain the correlation between E2 dominance and progesterone deficiency and how to specifically utilize a salivary panel to diagnose and treat this condition?
Very good, thank you. On one hand, I think you've already gathered from Dr. Mead's discussion and maybe your own work that estrogen dominance and progesterone deficiency are virtually synonymous. We're talking about a relative deficiency of progesterone as we watch estrogen have more impact and more relative functioning as women age, because the progesterone's going down. And so you can think of those in a similar manner. And it's a great question because people will often see a study on a perimenopausal woman and she'll be estrogen deficient, but we'll also use the terminology estrogen dominant in that she's got enough estrogen to be running amok in the sense that there isn't enough progesterone there to be opposing it. And so you can even have both of those going on at the same time. But if you think of estrogen dominance as progesterone deficiency, that might clarify that a little bit. When you get your testing done, the ratio is usually calculated for you. And what was determined mainly by Dr. Lee's work, but many others have continued in that path, there's a ratio for both men and women that we should be hitting for risk prevention. And we're really talking about the proliferative effects of estrogen with breast cancer and, for men, prostate issues and cancer. So keeping or raising a woman or man into that ratio has positive effect. And sometimes we're asked, if you look at a saliva test result, the range that we want to see women in is between 200 and 600 on the progesterone to estrogen ratio. And, you know, as people start to think about that and they calculate a little bit, they say, hey, wait a minute, nobody's in that range. And as we're talking about people in their 4th, 5th, and 6th decades of life and beyond, that's true. It's a number that's not a normal physiologic number, it's a risk preventative number. And we're there to optimize health. And as we obviously live decades beyond what we're programmed to live, this is one of the things you can be doing to prevent the very common incidence of the breast cancer and prostate issues.
Oh, wonderful. Thank you. Dr. Mead. Could you please explain to the audience the necessity of using a salivary panel to diagnose hypoadrenia rather than using what most of us are familiar with, an AM/PM serum panel?
Thank you. It's a good question. Well, as I hoped my presentation clarified for you, that saliva, because of its unique characteristics in the salivary gland as being a sieve and keeping the protein and cellular elements out of the matrix, that you're actually looking at a free level. So cortisol binding globulin is not going to affect our levels. So we're actually going to see the bioavailable level of the cortisol. So saliva should be tested. Now, the issue of when to test, the AM/PM cortisol, you're going to have to go to the laboratory for that if you're doing the serum, and the labs usually don't open at the time that you peak, and your peak again is 30 minutes after you awaken. And then that afternoon level, it may or may not be accurate depending on how much cortisol binding globulin the patient has. But it's very important, and we see this often in the tests that we interpret, is that even in saliva, if you just get an AM/PM, you might miss those that noon and before dinner sample showing a flat line. And we see this occasionally where somebody has a fairly robust AM sample. And if you just have that, you might think that everything's hunky-dory with the adrenal function. But if you get those other four levels, you see that they may drop right down and they're flatline thereafter. And this is one phase that we see in adrenal fatigue. It's not an on and off switch. The adrenal glands fade over time. And hopefully we catch them before they are flatline completely. The fact that they can have a little AM production is great for them. It means they're going to likely recover. And we're doing the things that we do, we can help them recover.
Thank you. Dr. Woger, the IgG study through the University of Miami has established a specific criteria in their interpretation of the results that are required through immunolaboratories. Could you please share with the audience these criteria?
Yes, we'll be using the scoring system for the results are a 0 through 4 value. And so we'll consider a patient to be positive with anything from 1 to 4. I suspect for patients who have a large number of positive results, we'll try to get them to focus on the 4s and the 3s, the ones where they have the highest reactivity level, but they will be given all of their results, and our goal will be to have them avoid any food where they scored a positive value.
Terrific, thank you. And Dr. Warden, what role does genetic testing play regarding epigenetics, and how would a practitioner use the interpretation to bring the patient to homeostasis?
Well, I think it's a little convoluted at this time. We do have genetic testing, some that I use in my practice. One is by a company called SpectraCell. There are other companies out there, but I find one in particular that they do very, very beneficial. It's an LLP, and it's looking at the density of the lipoproteins in cardiovascular disease. It looks at insulin resistance. It tests many things that we know that have to do with the cardiovascular system, and it's a great tool for helping your patients and teaching them about why they need to make those changes that will make the epigenetic changes. They also do a vitamin mineral profile. They do it on white blood cells. It takes about 2 to 3 weeks. They grow it out in those white blood cells, and it's truly a type of genetic testing that I think is beneficial. Another company, Genova, does some beneficial testing as well. But as far as genetics, we can map. There are companies you can go to TGen, you can go to Biodesign at ASU. And I was so excited when I found out I could get an entire map of all the genes in my body that we know of now for about $600. I thought, well, that's great. I'm going to do it. And then I thought, well, what am I going to do with the information? There are certain genes that we understand are identified or have a play in certain diseases. However, there are different types of genes. Some of our conditions there may be 20 or more genes activated in a particular type of cancer or disease state. So we don't know enough to take a gene map and say, let's work on that. But it might be valuable for about 23 to 30 of those genes to say, we have a pretty good idea that this is indicated in this disease state. Now, what can we do from a prevention standpoint? But some genes are activated within seconds, and they signal other genes, the intermediary genes, and then there's advanced genes that may take years to be activated. So we don't know enough at this point. But those particular ones I talked about have been very valuable in my practice, if nothing more than motivating the patient.
Terrific. What I'd like to do at this time is I'd like to open the floor to any questions from the audience. There is a microphone that's set up in the middle of the aisle. If you do have a question, please go ahead and step up to the microphone and you can ask a question of any one member of the panel.
Great to be first.
I guess the question is for anyone on the panel, probably Dr. Mead or anyone. So our last speaker was, I have a couple of patients, women patients, breast cancer patients. They have positive receptors for estrogen and progesterone. So now I'm like a little extra confused with this estradiol added on. So should I be giving them estradiol and progesterone or just stick with the progesterone? You could clarify that for me.
Well, I'll take a stab at that first and invite any other comments. That is a controversial topic, certainly in the allopathic community and the oncologists that we've brushed up against. And certainly would not use any hormones in that situation. And I would not use estradiol in that situation. I showed you the Chang study where if you give estradiol, the mitotic index of the cells, the normal cells, went up, and that certainly would be a risk, I think, for the cancer. However, on the other side of that coin, if the progesterone receptor is there and it's on the malignant cells, you could only hope that if progesterone hits that, it will do the anti-estrogen business that it does in a normal cell. So I give all of my patients who have breast cancer progesterone. In fact, if a woman has a nodule, and even if it's been biopsied, and particularly if it's been biopsied, I would say, and she's going to go in for an excision, I have her put progesterone all over that. She can treat that right up to the day of the biopsy. And there are studies that show that women who have higher progesterone levels at the time of their excisional biopsy have a better prognosis. So I think it's encouraging. In fact, I think the data supports that just having the progesterone receptor alone, even without progesterone therapy, has a better prognosis than a breast cancer that doesn't.
Thank you, Dr. Mead. Anyone else on the panel like to address that? Okay.
Different question.
Yes, please.
Dr. Mead, this is about menopausal hormone usage. Hormones are wonderful, both afferent as well as efferent systems. We're constantly, looking at the outside world, and then the hypothalamus responds efferently to the same hormones. With cortisol, we maintain the diurnal rhythm. With thyroid, it's pretty much understood that it's morning dosing. In a menopausal woman, why don't we maintain a lunar calendar and cyclical hormones rather than flat dosing of hormones? Finally, when you talk about progesterone, it requires an estrogen receptor to make progesterone receptors. So why are we only using progesterone for our patients and not estrogen in a cyclical fashion like we would when we were in our 20s and 30s?
Well, there are several questions in that, and all of them are good. As I attempted to show you in my schematic diagram, and is borne out in the number of, we have over 50,000 patients now in our database. Most women don't need estrogen. That is, they have levels that they would have produced when they were ovulating. So understanding that all breast cancers are associated with estrogen, we don't routinely give estrogen for that reason. And when Dr. Lee showed us that if you give progesterone, you can cover all of the estrogen deficiency symptoms in most women. And so, and that's the point that, I try to emphasize that, is that menopause and the symptoms associated with menopause are not an estrogen deficiency. They're generally a progesterone deficiency. Now, some women need estradiol, and that's why you measure. And it's extremely important to measure because you want to catch those women who need estradiol for their bone health and their cardiovascular health. And so you want to give them estradiol, and we do that in the form of Biest, which is a combination of estradiol and estradiol. And we would be glad to share dosages with you if you'd like to go into that. But probably offline would be a better place for that. Now, the question about cycling, Dr. Lee suggested that even with progesterone, that you go 3 weeks on and a week off. His idea was that you didn't want to downregulate receptors. Now, and this is where I've kind of drifted away from his principle, in that I treat a postmenopausal woman. Of course, a woman cycling, she gets cycling hormones, but if we're talking about a postmenopausal woman, I found that my patients didn't want to go off, and a lot of them didn't, even though I suggested they go off, because they didn't feel good when they were off their hormones. And I feel pretty comfortable about giving them 20, 30, 40 milligrams of progesterone a day. Again, I don't think we're going to harm them or downregulate their receptors. So for the women who didn't want to cycle, I agreed to that, and they went on now. And I have patients out years who have not cycled those hormones, and they've not developed a tachyphylaxis to the progesterone. So I know that's somewhat controversial, but in my practice, I just, if they want to take a break, I tell them to stop the 25th day of the calendar month and then start again on the 1st. Did that answer your questions? Okay.
I'd just like to bring up another point. First of all, let me preface this by saying that yes, I use bioidentical hormones with appropriate testing, but it is my last resort. And I think that something that we don't need to forget is that other women, especially in Asia and so forth, that look the same on labs that our American women do, don't have the same signs and symptoms that we do. So I just need to bring that up so that we remember that, again, we're stuck in our biochemical minds and our hormone pathways and this and that. But why is it that they can look the same on labs and not have the same signs and symptoms?
Yeah, I think that's an excellent question, and may relate to iodine or some other deficiencies.
Maybe, or they view, one postulation has been that we see it as a drying up, old age, not good for anything anymore, can't carry children. And they view it as now they're the wise woman and the leader in their community, and they view it very differently. They look forward to menopause, whereas here we battle it.
And if I could dovetail onto that a little bit, we see a lot of women drifting into insulin resistance.
Yes.
And they feel awful, and I think that may amplify.
I'm sure there are
the
physiological
symptoms that they're experiencing.
A question about timing of saliva cortisol testing. I have a lot of patients who work in the hospital. They work shift work. I have teenagers who sleep in, and I've been told by the company that I use for saliva testing that I should do it at the time that it says on the tube, no matter what. And so I was wondering what your opinion was about that.
I think we all were shaking our head.
We all shook our head, no. We're all the same, so go ahead.
The night shift workers, do change their diurnal pattern somewhat, but not entirely, and you'll find that they have a lot of symptoms and a lot of problems. With that said, if you're doing therapeutic physiologic work with hormones, you're going to need to test them when their morning is and when their nighttime is, and so you will alter the times based on what their daily schedule is. It gets tricky for those workers because sometimes they try to go back to a regular schedule 2 days a week when they're off, and then they go to their work schedule. And, regardless of how civilized and sophisticated we get, the light-dark cycle is still a big regulator of, what our bodies want to do. And so they're more prone to several things in terms of melatonin not being secreted at the level it should be. So I do alter that. If it's a routine and they're going to be in that for a while, I will alter the timing based on their day, meaning 30 minutes upon awakening for them is not at 6:30 a.m. It'll be when they awaken. And let me just clarify on that, since I presented the literature on that. Somebody said, does that mean when I'm awake or when I get up? Or, questions about what does 30 minutes after awakening mean? The brain wakes up at a certain point. You may or may not get up. But there's a point at which we could all say, yes, that's when I was awake. That's awakening. It doesn't have to do with getting up out of bed. You could have your tubes next to your bed, time it 30 minutes, and stay in bed if that's the schedule someone's going to do. But it's based on 30 minutes after that awakening response when the brain is awake. And if you don't relate to that, we all know what it's like to be laying in bed in the middle of the night and our brain has awakened. Cortisol has squirted for whatever reason and we're wide awake. Yeah.
Wonderful. Thank you.
First of all, I thought it odd that the lights came up on that particular
Yeah, and up and down.
I wanted to ask you, is that blinding up there, or is it okay?
It's okay.
Is it okay?
No, it's blinding.
Don't look at it.
Down a little
Don't go
bit.
toward the.
Oh, you can't turn it down?
I thought we were
For the video,
attracting
can you
moths.
still get the video, Greg? Poorly?
It was okay the way it was.
It's all right.
It's fine.
We're
If
fine.
that's what
We
you
can
need,
hear
Greg,
you.
why don't you go ahead?
Just look.
I had a couple questions. First of all, since all 5 of you, oh, probably they've got this speaker on too. Okay, since all 5 of you are in clinical practice, and since Immunolaboratories is a diagnostic laboratory, I know you use SpectraCell and Genova you mentioned. What's important to you, the 5 of you, in terms of a laboratory, what they provide to you? What's most important?
Well, I've toured most of the facilities that I use, including Immunolab, years ago. And even nutraceuticals that I use in my practice, doctor's line, I have been to their manufacturing facilities and learned over the years the right kinds of questions to ask as far as quality control, reproducibility, all those things. And I think that may be a class for next year, teaching physicians the right kinds of questions that you should be asking your labs and your companies that are preparing your nutraceuticals.
Would you like to interject, please?
Well, I agree with that. Reliability, reproducibility of results, rapid turnaround time. Patients pay money, want to get information right away because you want to also catch them while they're interested and are enthusiastic about maybe making some changes. And customer service. I'm newer to this than other people on the panel, so I also need to find companies for each of these areas where I can call as a provider and get the information I need. And so those are some of the things I look for.
All those reasons are important. Turnaround time, quality of testing is, I think, on the top. I think following that from a practitioner standpoint, turnaround time, because I don't want to have to cancel appointments.
Right.
I want that data there so when the patient comes in again, there's nothing more irritating to me than have to cancel an appointment with the patient there because I don't have the data. Mm-hmm. They're irritated, I'm irritated, and I have an hour slot now that I can't fill. Mm-hmm. And then customer service, I think it's extremely important. Now, what I would like to say about saliva testing, unlike standard testing that you would get from LabCorp or Quest, where they get blinded samples because they get accredited by various bodies. For example, the College of American Pathologists. And they get blinded unknown samples for whatever analytes they test, and then they send the results back and they get graded on that. And so you can be fairly certain if they're certified by a body like even the College of, what's that, JCAH, for the hospital labs. You can be fairly certain that they're giving you good numbers. Now with saliva testing, there is no such body to give us blinded samples. So you have to trust that your saliva lab is doing it correctly, which means you've got to trust the medical director. You've got to trust, so ask the medical director their credentials, ask them how they validated their testing, how are they validating their testing, how did they check that their results are correct. And so those are very important questions, I think, for saliva labs. And I think there's been shoddy saliva testing out there for some time, and I think some labs continue to give shoddy results. So just to throw that out so that you understand that.
I would like to also interject. I've been to all of the laboratories that have been mentioned. I've been to SpectraCell laboratories, of course. I've been to immunolaboratories as well, as I had the privilege of being taking a trip and visiting Dr. Mead and Dr. Lohman at Labrex. I tested with other laboratories. I think I tested actually with all of the other saliva labs before. I had the privilege of meeting Dr. Mead at last year's conference. And I can certainly tell you that I was highly impressed, Dr. Mead, when I did visit your laboratory. I was very impressed with the fact that the quantitative levels that are acceptable, the curve that is acceptable, is very tight. And when you had mentioned at the time of the visit that if it is so many points off of the curve, that test is trashed and the test is redone. and that's very impressive. And it's the same as with SpectraCell Laboratories and as well with immunolaboratories. I had actually used another laboratory for food allergy testing prior to coming to immunolaboratories. And when I did some split sample testing and reviewing some of the results, my eyes were opened up to some really important information that I probably would have never had come across if it wouldn't have been for the fact that immunolaboratories said, hey, let's put it to the test. So it's very, very important to have the most reliable information, especially we're taking these patients that, for the most part are coming to us with some urgency. They really, they're looking for some answers, and they've probably been searching for some time. So it's very important to have the tools that are necessary, including the diagnostic tools that are necessary to be able to help those patients.
And another question you might ask your laboratory, particularly a saliva lab, is, are you New York accredited? We just got our accreditation, and I want to tell you, they look at you very closely. So there's another benchmark, and I know Immunolabs just got their New York certification as well. And I don't know about, I think SpectraCell may have it.
I think they do.
Yeah.
I believe they are.
I believe they are as well. Yeah.
Another question from the floor.
Questions, one for Dr. Mead and one for Dr. Wolger. What is the age cutoff for hormone replacement therapy, especially in women, for Dr. Mead and for Dr. Wolger? What do you do with the +1 and +2s in the immunoblueprint? When do you reintroduce those foods? Thank you.
You want to go first?
Sure. So the question was for the +1 and +2s?
Yeah, do you reintroduce those foods at some point in time, or
Yes.
do patients stay off forever?
Well, it would also depend on symptoms. I have the patients really pay attention to their diaries, to their response to removing the foods, and if they feel as though they can gradually add things back in, we'll experiment a little bit. But I prefer to go at least 6 months, if they will, with complete food avoidance on those.
Coming from an immunological point of view, we typically look at a benchmark. The antibody levels are only going to be, the life of the antibody, the IgG antibody, is going to be between 27 to 36 days. If you take the patient on a full elimination off of the offensive foods, you're going to reduce the inflammation in the immune system. Therefore, those IgG antibodies are going to reduce. The rule of thumb, of course, is 90 days. For the +1s, 120 days for the +2s, 180 days for the +3s, and typically a year or more for any of the +4s.
Can I just make another comment on that? I guess the other way I use the testing is a mechanism to teach people about food, because it seems like there's so little knowledge and there's so much. One of the speakers at some point today talked about this restaurant mentality, where people are going out to eat, not preparing the food themselves. So I also try to use it as a tool to get people to get back to basics, getting back to fruits and vegetables, preparing their own food, not using something that's made from a box. So if I can extend that for 3 months or 6 months or 9 months, it's helpful. So because compliance is variable depending on the holiday season or the travel or vacation schedule or whatnot. So the longer I can extend that, the more I think I can help them retrain getting back to fresh fruits and vegetables, preparing their own foods, taking their food with them so they're prepared and not at the whim of whatever was prepared for them in a social setting and that sort of thing.
Absolutely.
One more clinical pearl before we get off on the other question is, I was in Europe, and it was a lab there doing IgG testing that told me that when you introduce those foods, and I agree with those times immunologically, but when you introduce those foods, it's very difficult to know whether they are really causing an inflammatory reaction. Have the patient weigh themselves the day that they introduce that food, weigh themselves the next morning. If they've gained over a pound or so, that's possibly inflammation, water weight gain. I tell the patient you can't gain fat or muscle that quickly overnight, but you can have an inflammatory reaction, and it may not bring back their cough or their sneeze or their belly fat overnight, but it might cause their weight to increase.
There was a couple of years ago an article that I read, and I thought it was actually quite interesting. It was in a psychological journal, and the article had read that it takes typically 1 week for a child, and they specified a child being from the age of 0 to the age of 13. It takes typically a child 1 week to learn a new process. It takes the average adult 3 months. So when we start looking at making alterations, what we are doing is we're making lifestyle changes and modification with not only their diet, but their whole lives. We're taking away foods and we're reteaching them how to eat. And I totally agree that it is a process. It can be a struggle for some and for others not, but it definitely does take that time.
The question about ranges.
Is there a time limit to doing hormone replacement therapy? I mean, especially in women patients, is there a cutoff in age? Do you still do it in 80-year-olds, 75-year-olds, and so forth? When do you stop?
Well,
when patients ask for it.
I stop when they tell me they don't want the benefit of the hormone anymore, and they stop themselves. I mean, that's their choice, of course. Now, I look at aging as a chronic disease. In fact, that's what it is, right? We become catabolic and we start deteriorating. If an 80-year-old came into my clinic and said, I don't want to deteriorate anymore, any faster than I am, can you help me move, regress, help regress the aging process for me? By all means, I will. And I'm aggressive that way. I'll use growth hormone if it's indicated. Had some amazing results. You see, nutrition and exercise and all of that is absolutely essential, but we're programmed to die. And if you want to do anything about that program, hormones definitely can help intercede in that area and to take it all the way up. Now, for males, I tell males that testosterone is a poor man's growth hormone, and it works extremely well for dealing with the catabolic process in males. Females, it's a little more complicated, but there are growth hormone products. I could do, maybe next year you invite me back and we'll talk about growth hormone. There are new products now that are absolutely amazing. You don't have to inject growth hormone now. Some of these products are very promising as stimulators for growth hormone release.
Let me just add, I think I mentioned earlier, but that program to die at around 45 or 50 years old. So it's a person's judgment call whether they want to be on hormones. I'm not trying to convince someone, particularly in the arena of estrogens. But if they do, remember that we today and the last presentation as well, we're talking about physiologic dosing, and we're talking a lot about monitoring. And we're not doing this without some sound diligence behind how we're approaching it. Most women I see don't want to go off hormones once they're on them. They feel good, and if you remember, I'm a believer of conservative physiologic dosing. Somebody asked me earlier about a protocol that's very popular out there right now that uses 3 to 5 times the amount of hormone I use. It's bioidentical, but I feel you recreate risk again, and you're going to run into trouble if you're using huge amounts. But physiologic dosing you could use for the rest of your life.
I have a comment and a question. My comment is I bristle when I hear that Asian women don't have symptoms and maybe it's cultural, being a menopausal woman and knowing what it feels like to have cognitive dysfunction when I'm not on hormones, and to know that I can't do my job as a physician the way that I need to. I don't like to downplay how serious this can be for women who are expected to perform the same way at 60 as they are at 30. And I think that, yes, this may be cultural, maybe in Asian societies where women are looked at as the wise person in the society and don't have to perform in certain ways. And maybe they can sleep in if they don't get sleep at night. I don't know. But I really do honor the fact that women suffer and they need to be helped. So I just needed to make that comment. And the other question that I have...
Thank you. And let me just add, we have groups of cultures that are under-reporters. They're not going to talk a lot about their symptoms or what's wrong.
Right.
And you could liken it to the American male here, in terms of there can be a whole host of physiologic things happening years before you'll see them in your offices, but culturally we've taught them not to be reporting that. Right. So, I mean, it's all in the mix, and I think all of what's been said is true, including...
Before you go on with your question, I'd just like to comment that I appreciate your comment, and I didn't mean to downplay symptoms. What I'm saying is there may be other things involved, your cortisol, your adrenals. Being a physician, you've got other issues going on besides sex hormones, and the hypothalamic pituitary axis is where it all starts, and that HP axis, I think, is where we need to be looking, and that is emotions, stress, all those things. That was what that was meant to bring to light.
Okay, thank you. And then my other question is, if most menopausal symptoms are truly just either a lack of progesterone or an estrogen dominance, I'm wondering why so many of my patients, when their patch, if I use a patch, as it wears off and they're still on their progesterone, as their estrogen is coming down, they start having symptoms then, because at that point their progesterone actually is higher than it was earlier on.
Excellent question, and thank you for being bold. I'll tell you an anecdotal case. My IV nurse, she was an excellent nurse. She headed off for work to come to the clinic one day, and she ended up in the supermarket. She's standing in the supermarket, and she's wondering why she's there. We got her on progesterone, and all that cleared up. There's a mental fog and a cognitive dysfunction that happens with hormone imbalance. Now, I would have to know more about your practice to be more direct about your question. In my practice, not everybody gets estrogen because I don't think they need it. I think the patch is terrific, though. And some women, particularly if they've been on Premarin and they want to get off of Premarin, to try to put them on a biased and pulse it that way, generally they don't like that. Within a few days they're on the phone and they wonder what I did to them. So I learned, if I'm going to transition them, I think the patch is an excellent choice for doing that. So I don't know if you measure your patients before you do it and establish that they need estrogen, or you routinely put them on the patch. Because the risk of doing that would be to upregulate or to, this is a harsh word, I don't have a better word right now, but addict the patient to a hormone. And we see that a lot with patients who have very high estrogen levels, and you just try to drop that a little bit, they get very upset. And a lot of their symptoms will come back. And so what you have to do is gently move them down and try to get their levels back in physiologic range. So I trust that you're measuring your hormones using, hopefully, saliva, and that you're treating and looking for that ratio. And if you get that ratio balanced, fine. Even if they are on a patch, it's okay. Maybe they didn't need it necessarily, but you've got them on it, a low dose, and they're feeling good. You don't have to alter that, but just make sure their progesterone's up.
I would add that the body reads change, and estrogen also, it's a whole other topic, but it can be a pretty central part of a woman's sense of well-being. And so if we're not even talking about numbers, but compared to what they had been premenopausally, they go through menopause and they've lost this sense of themselves. That sometimes is only re-established through some of the estrogen work. And so I'm not going to say women don't need that, but I'm going to say we're going to make sure we monitor it and have the ratio correct. But on this change issue, when you pull off a patch but you keep the progesterone in there, now the body has to read this new situation where there's no estradiol input, which it was getting, and it was getting very comfortable and happy with it, and now it's gone, and now you have a whole bunch of progesterone relative to that acting, and it almost looks like they're reacting to the progesterone. They feel awful. And generally, with time, that stabilizes. That's not a static state.
Yes, please.
This question is directed to Drs. Mead or Lohman. Regarding salivary testosterone, a number of years ago I ran a salivary level on a patient and got some results I didn't expect and talked to the lab about, and I was told at that time that insulin resistance will alter the salivary measurement of testosterone, and I'm wondering, I don't think I heard anyone talk about that today. I'm wondering if you can comment on that.
You know, I did talk about it in reference to insulin resistance, and you'll see it particularly in women. There may be a slight rise in men, but it's relative to what they'd normally have. You won't see the physiologic effect. Women, high insulin, that hyperinsulinemia actually upregulates both the thecal cells of the ovaries to produce more testosterone, as well as the adrenals to upregulate conversion to testosterone. So you're getting a double whammy, and you are going to get high androgens from that.
Well, this was a case where the lab was saying that in the case of insulin resistance, that the salivary measurement of testosterone no longer correlated with the production of testosterone. There was a decoupling. And essentially the salivary testosterone measurement became inaccurate with insulin resistance. And that's different from what I think I hear you saying now.
Absolutely.
No one's experience.
We see a correlation with insulin resistance and increased androgens. It can be either DHA or testosterone or both. It's pretty strong in the medical literature. I don't know about this decoupling idea. It sounds like the lab's trying to explain something they don't understand. That's what I think. I want to mention about estradiol. Using a patch is a great idea. Using topical is a great idea. Swallowing it is a bad idea, even if it's bioidentical. And we can, I think we have our reference list out there. I have 10 articles I found in the medical literature. Serendipitously, as I was reading about growth hormone, and I read 120 articles on it before I felt comfortable about looking at using growth hormone, there were 10 articles that just popped out that showed if you swallow estradiol, bioidentical or pregnant mare's urine, however you get it, if you swallow it, you're going to lower your IGF-1 levels. So and that's why I think topical, and certainly don't swallow hormones. Either inject them, put them on use your patches, use them topically, but don't swallow them.
Am I on? Are you a question? Go ahead.
Who wants to answer. I was wondering what your experience is with treating women that have a paradoxical experience with any type of progesterone. In other words, they get depressed, they get bloated, they feel terrible. What do you do with those cases?
I'm going to just say about 12 years ago I heard a clinical pearl from a clinician who had been using bioidentical hormones for a long time. And for some reason, she said, and I can't explain the mechanism, and maybe you folks have something, but she said, once in a while you'll get this paradoxical reaction, and I will switch to sublingual progesterone. We still don't want to give it orally, but she said, when I switch, they're able to absorb it. My testing shows it's there, etc., especially in PCOS and some of the issues that I spoke about today. Well, having heard that, I began to try it clinically and have over a decade of doing that. It's less than 7-8% of the time that happens, but when it does, I will often switch over to a sublingual form and not have the problem. But it is a paradoxical response where the very things you're expecting to treat, like breast tenderness, depression, anxiety, sleeplessness, all these things that progesterone is great for, it causes or it exacerbates. And so there's some absorption differences among women as well.
I kind of look to the liver, phase 1, phase 2, and see what's going on there. You would think that it would be affecting the estrogens and everything else as well, but for some reason I have found that liver downregulation, if it's toxic, so to speak, and not regulating from phase 1 to phase 2, that I found that correlation a little bit. It was just a thought process. I started checking it in patients, so I would encourage you to maybe look at their liver function.
And just another thought on that. And Erin accuses me of this occasionally being a male. I don't think like a female doctor would. But one thing that we know that happens when you give progesterone is that you upregulate the estrogen receptor transiently. So you can get tender breasts and some water retention and so forth. So I just have the patients lower their dose of their topical and see if I can bring them back up. So I don't use sublinguals because folks swallow some of those. I don't care how good they are. They swallow some of that, and you don't know how much they swallow. And then your salivary test is confounded now because you've got something in the mouth, and you have, in order to get close to an accurate result, you at least have to wait 24 to 36 hours. So now you have to question your therapeutic levels, so which are established for 12 to 24-hour window using your creams. So, but she gets very good results, and I love her. So.
Incidentally, on the sublingual testing, if you have your patient drink 2 glasses of water after their last dose prior to testing, you're not going to see all that contamination type stuff. If you've been working with that form, you're going to have, I heard that also, clinical pro from a doc who's been doing it 25 years, sublingual and saliva testing, that after the last dose, let's say they're going to test the next day, they've taken their last dose of hormone, he makes sure at that time it's dissolved, then they drink 2 glasses of water. And we're doing an in-house study right now, and we do not have any results published or ready at that level, but it's looking to be true. That with the 2 glasses of water, you know, there's a 24-hour window, not unlike the topical hormone timing.
I just wanted to ask, a little earlier, Dr. Woolger and I were discussing a study that had come across my desk in the last couple of weeks. And in the study, it was a group of women that had no history of thyroid issues at all, and they were in the normal TSH range. But what they said was that the women, as they followed them, that the women that were in the lower TSH range, that they had a 70% less chance of heart disease than the ones that were in the higher TSH range. And so they were suggesting that by supplementing with a little bit of thyroid, even when you're in a normal TSH, that it could in fact reduce heart disease in women. So I wanted to see if you heard of that study and if there were any comments.
We're all for that.
Yeah.
Besides just TSH, free T3, free T4, seeing if they're converting or not, it's not, you're looking at the active downstreams. TSH alone doesn't tell me really anything if I don't see the downstreams. High or low, according to the body, having a negative feedback or not. So I think you've got to look at all of it. And don't forget, again, that HP axis, that pituitary, hypothalamic pituitary axis, that is the signal for the thyroid.
The TSH level is sort of a joke in the way most laboratories present the data to you. They'll give you a range of 0.4 to, say, 5.2. And most endocrinologists, if you fit in that range, they'll turf the patient. They won't consider thyroid hormone. And if you are going to use that marker, and even in the best hands, it does have some issues. Maybe the pituitary gland can't make it, and so you might artificially think your hormone levels are correct if you just measure a TSH level. But assuming that axis is working, and the brain is trying to tell us that the body needs more thyroid, it's the principle, get that TSH level down to below 2, and I always shoot for 1 or less. I mean, that's artificial to have that range that high. Again, it's about optimizing hormones, not treating the lab and not the patient.
Remember, that's a really crude screening. It's not a precise test, and in fact, it was an interesting little tidbit. We were lecturing in St. Louis this spring, and an endocrinologist lectured before I did, and he happened to be close friends with the endocrinologist that invented the TSH test, however many years ago. They were in medical at the same university. And his friend said to him, the man who invented the TSH, was able to develop that, he looked at this man and he said, I hope this doesn't stop clinicians from thinking. He understood its limitations. He understood what it was as a screening tool, a very gross, broad screening tool that doesn't tell us too much, but when it's way out of range, high, it does. It's a useful indicator.
Basal body temperature, don't forget about that. I know it's controversial, the Wilson syndrome type thing, but it does correlate, and I think we need to be looking at that as well.
You certainly can't overlook the fact that I find that a lot of physicians that are out there, they're testing for thyroid disorders, they're looking only at T3, FT3, FT4, and TSH. But, there's also, we need to be looking at the microsomes as well, because more and more women are developing Hashimoto's, and it's going undiagnosed. And you have a woman that comes in and she's having all sorts of symptomology, and she should have been diagnosed a long time prior so that she could have been treated correctly.
Absolutely. May I add a word about thyroid? I recommend measuring reverse T3. If any endocrinologist gives you trouble, the beautiful study from Amsterdam showing that if your reverse T3 is high, you are not converting T4 to T3, even if you have normal T3 free levels. Secondly, if you really want to get that TSH up, put them on some iodine. It'll open the gates for TSH. TSH goes up, they're happy, you're happy.
Thank you.
That's good. And the reason why I really brought that study up was because the women had absolutely no symptoms. And I wanted to, does anyone know on the panel the correlation between an increased risk of heart disease and having a lower TSH? Or I'm sorry, a higher TSH, yes.
To me, if you look at the extreme, you look at somebody with failure of thyroid production altogether, they develop heart disease. They develop a cardiomyopathy. So the thyroid has to affect the tone of the heart. That's again, just thinking physiologically without having a double-blind placebo-controlled trial.
But it makes physiological sense.
Yes, it's past the sniff test.
If someone is not on thyroid hormone when they come to see me, I do my adrenal work and my iodine work first, because there's a large percentage of them who present in a subclinical hypothyroid fashion, but upon correcting the other two symptoms will not need to go on to take thyroid hormone. Some will, and we'll still replace that as needed, but chronologically I like to do the others first because many people correct, and the thyroid upregulates.
That's a great point. It is absolutely. And we have to always take into consideration the fact that we are dealing with the endocrine system, and the endocrine system is tied together. It is not separated. So there is a correlation. When there's problems with the thyroid, there's going to be problems elsewhere. If there's problems with the adrenals, there's going to be problems elsewhere. So we have to look at the entire endocrinology system, and we have to adjust it accordingly. Yes, please.
I have a question that really would be nice to have been able to ask Dr. Tutera, but since he had to go. I'm not familiar with using FSH to follow therapy for BHRT because I was always taught that the inhibin prohibits us from doing that, or makes it so that we can't follow FSH. We don't expect FSH to fall with therapy. Can you speak to that topic?
No, I can. I listened to that presentation. What I try to do is keep an open mind. Obviously I do things differently than he does. He didn't mention progesterone except to treat women who had a uterus, which goes against principles that I practice with. And I've never tried to monitor FSHs.
I haven't either.
I haven't either. That was new to me as well.
Yeah, I don't know anything about
His
that.
data was there, but I've never seen anything like that before.
I didn't know if it was at his data or somewhere. I didn't know. I didn't see a reference at the bottom. I'm not sure where the data came from. Was it somewhere else?
She said it was from England. Oh, estrogen. Yeah, that's true. It wasn't.
Okay.
Didn't appear to be U.S. because it was with the O. Yeah.
Yeah, I would like to talk to him about that. I won't give estradiol unopposed without progesterone. Yeah, I don't. To me, that goes against all the principles that I understand. So.
Thank you.
Any other questions? Okay, we'd like to thank our panelists. Dr.
Well,
Powell,
thank you.
Thank you.